Hello, everybody. My name is Dr. Meron Auraris. I'm an assistant professor of neurology. Today, I'll be talking to you about stroke. My disclosures are the original content of this presentation was prepared by Professor Diana Seller. Coming to the definitions and epidemiology of stroke. Stroke is defined by the World Health Organization as a rapidly developing clinical signs of focal or global disturbance of cerebral function lasting more than 24 hours or leading to days with no apparent cause other than that of vascular origin. Stroke is divided into two major categories, ischemic and hemorrhagic stroke. Ischemic stroke is resulting from obstruction within a blood vessel supplying either any of these structures, the brain, the retina, or the spinal cord, and hemorrhagic stroke is rupturing of a blood vessel supplying a brain or any of the above areas. And there is another category known as the transient ischemic attack or a TIA. TIA is basically a spectrum of an ischemic stroke that never happened. It's basically a warning for ischemic stroke. So it's defined as a transient episode of neurologic dysfunction resulting from focal cerebral, retinal, or spinal cord ischemia without the evidence of acute infarction. So basically, when you do brain imaging, particularly brain MRI with diffusion sequence, diffusion-weighted imaging, you don't find any restricted diffusions. That means so imaging is normal in TIS. So coming to the epidemiology of stroke, stroke is basically a growing public health problem, particularly in low-middle income countries. And worldwide, there is around 17 million strokes happening each year. And it's said that every 2 seconds, this translates into having one stroke, one person being attacked. And it's said that 1 out of 4 people will get stroke in their lifetime. So globally, there will be happening 6.5 million cases each year. And around the world, there are around 26 million stroke survivors. So 10 million disability-adjusted life years are lost due to stroke in high-income countries. And around 52 million disability-adjusted life years in low-middle income countries. There are different literatures highlighting stroke, how it is becoming a public health issue, a crisis, particularly in Africa, in that of the sub-Saharan African region. And stroke, why is it really important in the sub-Saharan African region? Because it's continuously on the rise, unfortunately. And why is it really important in Africa? Because stroke is 90% of stroke is actually preventable. So the major risk factor for stroke is hypertension. And if these literatures have come out a while back in 2003, 2012, 2018, but sadly, even to date, it holds true that majority of the patients with stroke, they don't even know that they have hypertension. They have never sought health care and they don't know their status. Even if they are told that they have hypertension, they don't take their medications. And even if they actually start taking their medications, they're not adherent. So 90% of the patients with stroke can be really prevented. One major risk factor being hypertension, the others decreased physical activity, obesity, and high cholesterol in the blood. All of these are manageable, if detected, are manageable things that lead towards the prevention of stroke. But this is not happening in the sub-Saharan African region. So stroke is preventable, and also it's becoming, it's really overwhelming the healthcare system. On average, the length of stay for stroke is greater than 15 days. So imagine, and if patient is developing bed sore and so on, that's even increased. So it's really overwhelming the healthcare system as well. So it's really important for these reasons, particularly in Africa. Plus, it's really, when you see the incidence of the age of patients with stroke, they are much younger compared to the developed world. So it's really affecting the working health force, the working force of the country. This map is color coded, and it's showing the incidence of stroke per 100,000 population. As you can see, in North America, for example, this was an age standardized incidence of stroke in 1990, comparing it 20 years later in 2010. So if you see North America, the incidence was in 1990 in the light pink category, 146 to 143. 20 years later, actually, they have really managed to decrease the incidence, the age standardized incidence of ischemic stroke to the light green region, that is between 130 to 164. This is a big improvement. So they have done this by early detection and prevention of and managing of hypertension. Okay. Whereas if we go back and see the incidence of ischemic stroke, the age standardized incidence, it has really increased in the sub-Saharan African region from 98.8 to 132 in the year 2010 to 164 to 213. So you can imagine. Same thing with hemorrhagic stroke, unfortunately. So you can see there is a major increase in the sub-Saharan African region, whilst in most of the other continents and subcontinents, it has minor increment or has stayed more or less the same. So in general, the incidence of ischemic stroke in Africa is 316 per 100,000 population, and in US it's 246 per 100,000 population. And as I have said, the major drivers of increased rate of stroke in Africa are mainly hypertension, and greater than 50% of the population doesn't, greater than 50% of the population is said to have hypertension, and most are starting at 35, even younger at the time of diagnosis. Patients are quite young, and as I said, the other remaining population doesn't even know that they have hypertension. Okay, and due to improved healthcare, there is aging of the population that also that also increases the risk of stroke. Increased smoking, diabetes, obesity, westernized diet, physical inactivity, and high rates of HIV are all contributors. Worldwide, ischemic stroke is said to be the highest, of having the highest prevalence, 85 to 90%, and that of hemorrhagic stroke is 10 to 15%. But in Africa, again, owing to uncontrolled hypertension, of course, hypertension is a risk factor for both ischemic and hemorrhagic, but due to the uncontrolled nature, we tend to see an increased incidence of hemorrhagic stroke, hypertensive hemorrhagic stroke again. And coming to the mortality of stroke in general, patients having hemorrhagic stroke have a 50% chance of dying, particularly in the first week of hemorrhagic stroke. And mortality from ischemic stroke is 20%. All right, coming to the clinical presentation and workup of patients with stroke. As we have said, the presentation is really hyperacute to acute. So within seconds, few minutes, or to very few hours is the presenting symptom. And deficits, clinical presentations vary based on the location of the stroke. If it's, for example, the language area that's affected, we may get speech abnormalities. If it's the motor strip that's affected, patients can come with motor weakness. So depending on the area of the stroke, there are classic stroke syndromes. And in general, clinically, it can be very difficult to differentiate between ischemic and hemorrhagic stroke. But in general, there are cues that may point us towards hemorrhagic stroke. That is, if there is severe headache at onset, if there is nausea, vomiting, coma at onset, or if there is seizure within 24 hours, that suggests towards hemorrhagic stroke. And the mainstay of investigation for stroke is brain imaging. Particularly, CT scan remains the gold standard, as it is. It has a high sensitivity to detect hemorrhage in the brain. Otherwise, CT is a bit less sensitive to detect ischemic stroke, particularly in the first few hours. So when I come to explaining this CT scan, the top one is showing a classic hypertensive bleed. You can see it on the right side of the basal ganglia. It's quite a huge bleed. It has resulted in compression of the ipsilateral lateral ventricle. It has also extended into the ventricles. As you can see, because blood has higher density than air, you can see the air fluid level here. This part, the hyperdensity, is actually calcification of the choroid plexus. Otherwise, blood tends to settle than the air in the ventricles. Okay, so this is a classic hypertensive bleed in the right basal ganglial region with intraventricular extension. And the lower CT scan is showing you actually a huge area of infarction in the left MCA territory. So this patient likely, since it's affecting the left hemisphere, the language area, as well as the motor strip, will probably be presenting to you with classic aphasia with the right-sided hemiplegia, okay? So this must have occurred quite in the late phase, so it's infarcted tissue. But otherwise, in the very early stage, like if you take a CT scan with particularly in less than 6 hours, it may miss an ischemic stroke. So it's the most sensitive investigation in detecting ischemic stroke is actually MRI, particularly what we call as the diffusion-weighted sequence, diffusion-weighted imaging, DWI, with ADC, apparent diffusion coefficient sequences are very important in detecting ischemic stroke in the early stage. So how does the DWI actually work? So basically, the DWI is an MRI sequence whereby the MRI the high magnet causes movement of water molecule. So water molecule tends to have restricted movement in the area of the ischemic stroke, because ischemic stroke results in cytotoxic edema and oozing out of protein materials and cellular materials. So water cannot diffuse easily. So it's restricted basically. So you see it as a bright area here in the right MCA territory. So you see the bright area here. So if you see this, it means diffusion restriction. So the ADC, or the apparent diffusion coefficient, calculates the degree of the ability for the water to move. So it's a numerical value and it's calculated based on the DWI. So in ADC, because the water is restricted and the diffusion is actually reduced, the ability to move around, so because the numerical values reduced, then the area of stroke becomes dark. Okay, let's go a little bit more in detail into ischemic stroke. So based on TOST classification, ischemic stroke is divided into 5. Basically large artery, cardioembolic, small vessel, stroke of undetermined etiology, and cryptogenic stroke. So stroke of other determined etiologies being meningitis, neurosyphilis, and HIV vasculopathy. So large artery strokes are basically from the large arteries that are supplying stroke when they are affected. So basically the anterior cerebral, middle cerebral, and posterior cerebral arteries. So as you can see from these images, the anterior cerebral artery supplies the topmost outer part, the lateral part, and the medial aspect of the cortex, and the MCA territory supplies essentially mainly the lateral aspect of stroke, and the posterior aspect and the most lateral inferior part is supplied by the posterior cerebral artery supplies the most medial and posterior aspect of the brain. Okay, so the left MCA syndrome, if we go back, because it's supplying the motor strip as well as the language area, you'll get hemiparesis, hemisensory loss because of affection of the thalamus as well as the parietal lobe, and of course the aphasias. So you'll have classically left hemiparesis, left hemisensory loss, and aphasia. And in right MCA syndromes, you'll get what the left MCA, the left hemiparesis, left hemisensory loss, as well as neglect. Neglect because your parietal lobe is affected, and the parietal lobe, mainly the right hemisphere, is dominant for visual spatial orientation. And in anterior cerebral artery syndromes, you get leg weakness and incontinence. Incontinence because the anterior cerebral artery region, the most medial aspect, is supplying the paracentral lobule. Okay. And in the posterior cerebral artery syndromes, you get acute vision loss because it's supplying the visual cortex, as you can see from here, the yellow regions. Okay. Just now. Apologies for the inconvenience. Okay. So the major risk factor for large vessel ischemic stroke is mainly hypertension and anything leading to atherosclerosis, such as hyperlipidemia, diabetes, carotid artery stenosis. So when you have a carotid artery stenosis, there could be plaque formations and so on that may embolize as well. So this can lead to large artery strokes as well. And then carotid artery stenosis also, it can also continue into the intracranial vessels. And then in this category, you also have dissections. So workup involves CT of the brain, MRI, echocardiography, carotid Dopplers, lipid profile, hemoglobin A1C, fasting glucose, RPR to detect presence of neurosyphilis, TSH and ASR to detect if there is any ongoing inflammation in the brain to screen. Okay. Another classification in the ischemic stroke is cardioembolic stroke. For cardioembolic stroke, the major risk factors are atrial fibrillation, if there's thrombus in the left ventricle, low ejection fraction, because when blood is static, when ejection fraction is low, then that creates a perfect opportunity for thrombus formation. So that can also embolize, and then hypercoagulable states with the patent foramen ovale or PF4 other major risk factors for cardioembolic stroke. Again, you need to do CT or brain MRI and then echocardiography, 24-hour EKG monitoring, particularly in patients in whom you are suspecting paroxysmal atrial fibrillation, but in those with chronic atrial fibrillation in whom you detect atrial fibrillation on chronic, normal routine EKG, then you may not need to do the 24-hour EKG, but in those in whom you are suspecting paroxysmal AFib, then you may need to be doing the EKG, okay, the 24-hour Holter monitor. And then if you're suspecting patent foramen ovale, you can go ahead and do your lower extremity Doppler to see thrombus embolization from the lower extremity via the right ventricle into the left ventricle, and then starting embolization to create stroke. And then depending on your patient population, you may also think to do a hypercoagulable workup, like in patients with having female patients having consecutive abortions in the earlier trimesters, in whom you are suspecting antiphospholipid antibody syndrome, for example. You can do those workups in those special populations, or in whom you think there is a hypercoagulable workup. So other hypercoagulable workups include, for example, presence of screening for malignancies and other inherited disorders such as protein C, S, or antithrombin 3 deficiency. So classically, cardioembolic stroke involves multiple vessel systems. In this on your right hand, you see a wedge-shaped DWI restriction in fluid restriction. Also on the coronal section, you see this parietal lobe affection. And then sometimes they can also be multifocal. You can see the fluid restrictions, multifocal or string of pearls, okay? In small vessel strokes, they are also called as lacunar infarcts. They're usually less than 3 centimeters. Again, for lacunar infarcts, the risk factors are mainly that of hypertension, diabetes, obesity, and hyperlipidemia, and you can do the workup accordingly. So earlier we said there are classic stroke syndromes in whom when you find it, then that will be able to really point to a certain location. So classically, the lacunar syndromes are that of pure motor, pure sensory motor, dysarthria clumsy hand syndrome, ataxic hemiparesis, hemibalismus, or hemichorea. So if you get these things, they might point you toward this lacunar stroke. You can go through this table in detail. But for example, for pure motor, These are happening in, as I have said, lacunar syndromes are involving a brain area that's less than 3 centimeters. So when you get a pure motor syndrome, for example, if you get a dense hemiplegia, just only motor symptoms, then likely the area that's having a highly concentrated fibers in a dense area, in a small area, must have been affected. So these are, for example, the posterior limb of the internal capsule, corona radiata as it's coming down from the motor strip via the corona radiata to internal capsule, and then going to the anterior aspect or the basis pointis of that of the pons. So if you have affection of these areas, you may get pure motor syndromes, okay? And the blood supply for that region is the lenticulostriate branch of the MCA or the perforating arteries of the basilar artery. So accordingly, you may find these areas, you may go through this table. And then midbrain syndrome. So based on the affection, there are certain midbrain. For example, if the stroke is in the midbrain, you have what we call midbrain syndromes, pontine syndromes, and that of medullary syndromes. So in the midbrain, depending on the area of the affection and the patient's presentation, you have different syndromes. One of them, so in order to really clearly understand, you need to know the anatomy of the microscopic anatomy of the midbrain and also the brainstem. So here, what you are having is the midbrain, what is called as, it's basically said to have a Mickey Mouse appearance, that of the midbrain. So what we call the Weber syndrome is when you are having, so this dark area is called as it's basically the crus cerebri. And in that area, in the crus cerebri, you have the corticospinal tracts passing. So when you have affection of that one, you'll have a contralateral motor weakness. And the center, the circular part here is called as that of the red nucleus, which is basically having a connection with the cerebellum. And if you have affection of that, you tend to have a contralateral tremor, what's called as midbrain tremor or rubral tremor, which is quite a coarse tremor. And there is the third nerve, the oculomotor nucleus, and it's all the way down coming the fascial nerve, the third nerve branch, or what we call as the fascicles. So Weber syndrome, it is the light pink area. When you have a stroke affecting this light pink area, so it's basically touching the crus cerebri and the fascicle of the third nerve. So you'll have a contralateral hemiparesis, and you will have an ipsilateral third nerve palsy. Okay, patients could present to you with ptosis and impaired ipsilateral pupillary reflex with dilated pupil. Okay, so this is the classic Weber syndrome. In Benedict syndrome, you have affection of the red nucleus and that of the fascicle of the third nerve. So what's happening here? You will have ipsilateral third nerve palsy, usually with dilated pupils, and you have a contralateral involuntary movement because the red nucleus is affected. In Claude syndrome, you just have affection of the red nucleus and that of the fascicle. So so classically, the syndrome will be contralateral hemiataxia with dysmetria and also contralateral tremor. So here, also the superior cerebellar peduncles of the fibers connecting the cerebellum are involved. So you'll have hemiataxia syndromes as well. In North-Nagel syndrome, what's affected is the ipsilateral third nerve palsy because it's touching the fascicle. as well as you'll have contralateral hemiataxia because it's affecting the superior cerebellar peduncle. Okay, there are many pontine syndromes, but here we're describing the locked-in syndrome. Locked-in syndrome is affection of the ventral part of the pons, as you can see from the diffusion restriction here. It's very much important because it's one of the differentials for coma, particularly for vegetative states, okay? Because so vegetative state is a disorder of consciousness, but patients with locked-in syndrome, they are fully conscious, as you can see, because it's ventrally located. It's not touching on the reticular activating system that's located posteriorly. So patients are very much awake. Their problem is they are quadriplegic, so they cannot move their limbs. And then they also have horizontal gaze palsy. So basically, patients are also unable to speak. So they are completely deafferented. They are completely disconnected from the world. They cannot speak, they cannot move. But if you go closely and check the vertical eye movements, their vertical eye movements are intact, okay? And their blinking is preserved. So they are not in coma, but they are coma mimics, okay? So you should know about locked-in syndrome. So it results from mainly from basilar artery occlusion, but it can result in affection of the ventral part of the pons from trauma, from TB, from different reasons, but the most common cause is stroke. Okay, in basis pointis, when you have affection of the basal part of the pons, you may have clumsy hand dysarthria syndrome. And in the medullary syndrome, we have what is called as the medial medullary syndrome and the lateral medullary syndrome. You can go through this in detail, but in general, in the medial part of the medulla, it's mainly the motor as the corticospinal tracts are descending from the basis pointis and then coming through the medulla, they are traversing on the medial aspect of the medulla. So if you have a medial medullary syndrome, patients will have a contralateral hemiparesis because still the corticospinal tracts decussate at the lower part of the medulla. So the weakness here still is on the contralateral side. And because also the hypoglossal nucleus is located centrally or medially, you will have ipsilateral affection of the tongue with hemiatrophy and ipsilateral deviation of the tongue. And you'll have a contralateral impairment of fine touch and vibration because already remember your positioning vibration sense decussates at the lower medulla and sets to go on medially also. So since it has already the fibers decussating, bringing an ipsilateral positioning vibration sense have already decussated. So affection will result in contralateral movement of vibration position, and patients will also have ipsilateral and pharyngeal myorrhythmia in these regions, okay? Whereas in that of the lateral medullary syndrome, you'll have Horner syndrome because of the sympathetic chain is affected, ipsilateral ataxia because of affection of the inferior cerebellar peduncles, contralateral impairment of sensation of pain and temperature of the body because the spinothalamic tracts are traveling laterally, impairment of ipsilateral sensation of pain and temperature of the face because of ipsilateral location of the sensation of pain and temperature for faces located ipsilaterally. And then you'll have nystagmus. And then because of the ipsilateral vestibular nuclei are affected, and ipsilateral loss of hearing because of the affection of the cochlea, and then cochlear nucleus, and then hoarse voice and dysphagia because of nucleus ambiguous affection, and then cardiac arrhythmias because of the location of the, what we call it, the center for cardiac control center. Okay, coming to the management of ischemic stroke, if patients have come within the golden hour, particularly so in the past it was 3 hours, then expanded to 4.5, 6. Now even some centers in selected patients can give thrombolysis if the patients come within 9 hours, but they usually do specialized tests as well. And then these days for large vessel occlusion, the mainstay of therapy evidence are really growing towards endovascular therapies, mechanically, particularly mechanical, endovascular mechanical retrieval of the clot. So as you know, because there is central infarction, what we call the core, and surrounding it is the penumbra, the ischemic penumbra, in which the cells have not yet died. So in ischemic stroke, if we reduce the blood pressure too much, those struggling cells could die. So we don't want to reduce the hypertension too much. So in general, we want it to be, if for the first 24 hours, if the systolic does not go beyond 220 and the diastolic beyond 120, we don't in general touch it. For the first 24 hours, we want to give a permissive hypertension. But in those undergoing thrombolysis, we do want to reduce the systolic blood pressure to less than 185 and the diastolic to less than 110, okay? And then we do want to give, if we are not having IV thrombolysis, we want to give high dose aspirin greater than 150, sometimes even up to going 300 loading dose of aspirin if we get the patient within the first 48 hours. And then the mainstay of treatment, of course, is preventing complications in our patients, particularly aspiration pneumonia, because it's associated with increased hospital stay as well as increased mortality. So patients after stroke, before, first of all, those who are having a GCS of less than or 8 should be intubated, should have NG tube in place. And then even for all patients that are awake, we should first do a bedside swallow evaluation before patients take anything purpose. And then the head of the bed should always be elevated to 30 degrees. This not only helps in the decrement of ICP, it will also contribute a lot to prevent aspiration. So we should really elevate the head of patients of strokes in all stroke patients. And then DVT prophylaxis, maintaining euthermia, and then maintaining euglycemia, adequate hydration and nutrition is important. Early mobilization is very much important, okay? And their oxygen saturation should be kept above 94%, okay? And complications of stroke. So stroke edema tends to peak between the 3rd and the 5th day. So patients still could continue to deteriorate after even 48 hours owing to post-stroke edema. So this is particularly significant in those youngster patients because since they don't have cerebral atrophy, they don't have much space to accommodate the increasing edema. So they are likely to herniate faster compared to the elderly individuals who have atrophy and a lot of space to accommodate rise in ICP, okay? And another major problem is hemorrhagic transformation as well, okay? Okay, coming to secondary prevention of stroke. As you know, once stroke has happened, it's not a guarantee that you're not going to have your second, third, or fourth one if you don't have a proper secondary prevention. So patients should be on low-dose aspirin what we have is 75 milligrams, so 81 milligram and 75 milligrams, so they should be on low dose. And for patients having a statin lipid cholesterol level, an LDL of greater than 70, they should be placed on statins. These days they are saying there might be a place if in patients where you cannot determine the lipid profile, regardless of your LDL levels, everyone should be put on statins. And then you should also optimize cardiovascular risk factors such as diabetes and blood pressure. Okay, and then depending on your detailed investigations in the patients that need it, like for example, for those with hypercoagulable states and so on, you can institute therapy accordingly. For those with cardioembolic stroke, like with atrial fibrillation, they may need anticoagulation on warfarin or on one of the new anticoagulant agents, such as dabigatran. Sometimes patients could be allergic to aspirin, or they may have upper GI bleeding. In those situations where you cannot give aspirin, then you might be needing to shift to clopidogrel or platelet aggregation inhibitors. Okay, and then in those in whom you have found major carotid artery stenosis, so by major, I mean more than 70% up to 99%, you may need to do either carotid endarterectomy or stenting for those patients because they are at risk of developing stroke. And then for those having a stenosis of less than 70 but above 50 to 70, you need to do aggressive medical management. Okay, and then for those with those minor strokes of having an NIH stroke scale of less than 4, you need to put them on dual antiplatelets, that is aspirin and clopidogrel for 3 months. Okay, and for those with intracranial, so for those having a minor stroke of NIH stroke scale less than 4, they should be put on dual antiplatelet for 21 days. Okay, but for those with intracranial atherosclerosis, in established intracranial atherosclerosis, they should be on dual antiplatelet for 3 months. Okay, 21 days is for those with minor stroke. Okay, coming to TIAs, transient ischemic attacks. As I said, TIAs are an ischemic stroke that never happened, that passed away, just giving you a warning sign. Okay, so so these are great warning signs, but if we have not managed them aggressively, half of these patients, like 10 to 15% of patients will have stroke within 3 months. And out of this, actually, half of these strokes happen within the first 48 hours. So we really need to aggressively manage TIA. And to help us in the management, there is a scoring for TIA, what's called as ABCD2 score. So A being age greater than or equal to 60, they get 1 point. Blood pressure either 140, greater or equal to 140 or greater or equal to 90, gets 1 point. Clinical features, those with unilateral weakness, with or without speech impairment, they get 2 points. Those coming with just speech impairment with no weakness, they get 1 point. Duration of TIA, if it has lasted greater than 1 hour, they get 2 points. And if it has resolved in less than 1 hour, they get 1 point. And presence of diabetes gets also 1 point. So ABCD2 score, D2 for duration in diabetes. Okay. So accordingly, once you have scored your patients, you may classify it as having a point of 0 to 3, 4 to 5, 6 to 7. So those categories with 6 to 7 will they have a 2-day within, that is a 48-hour risk of having stroke of 8.1, imagine. But as the days go, also the chance of you having your stroke will increase up to 15%. So TIAs are very, very much important. So how do we work up a patient that has presented to you with a TIA? We need to do Doppler of the carotid, echo, prolonged EKG to pick any paroxysmal AFibs. If your regular ECG is not picking your AFib, and stroke labs, what we have discussed earlier, the lipid profile, hemoglobin A1C, thyroid function test, ESR, and all the standard stroke workup should be done in these patients, and they should be treated accordingly. They should be put on aspirin and statin, consider anticoagulation if you have picked AFibs or other indications for anticoagulation, and endarterectomy, carotid endarterectomy if you have detected a stenosis of 70 to 99%, or if they have stenosis on the symptomatic side. And then, of course, you should control the cardiovascular risk factors, okay? Okay, that was in brief about ischemic stroke. Coming to hemorrhagic stroke. Hemorrhagic stroke is also known as intracerebral hemorrhage. Hypertensive bleeds are the most common intracerebral hemorrhages, and they are usually located in the deep structures of the brain. That's why it's sometimes called as deep ICH. So they are mainly located in the basal ganglia, thalamus, and internal capsule. You may also see them in the cerebellum and the brainstem. And then sometimes you may also have a lobar ICH, more on the cortical and in the outer subcortical regions. And the risk factor for this is mainly cerebral amyloidosis, or what we call amyloid angiopathy. I'm sure you recall the CT scan we just displayed earlier. Remember the right basal ganglial hemorrhage going into the ventricles. That's a classic hypertensive bleed. It's deep within the basal ganglia. So that's a classic hypertensive bleed, okay? Risk factors for intracerebral hemorrhage, hypertension is the major risk factor, but you have others like cerebral amyloid angiopathy, particularly in the elderly, and then you have advanced stage, anticoagulation intensity. If patients have increased INR, they can come with you with the ICH. And then extensive white matter disease is also a risk for ICH. Prior stroke is also a risk factor for stroke in general. Hematologic abnormalities, CKD, trauma or falls, aneurysmal ruptures, alcohol consumption, excessive drug abuse like cocaine. Cocaine can give you both ischemic as well as hemorrhagic strokes, and low cholesterol. So cholesterol is said to be important in reducing inflammation as well as stabilizing the cell membrane. So having too much of low cholesterol can really lead to hemorrhagic stroke. So hypertensive ICH constitutes at least 2/3 of the hemorrhagic stroke. As we said, the areas affected by hypertensive bleed are the deep structures, mainly the basal ganglia. You may also have affection of the thalamus and the cerebellum and the brainstem, particularly the pons. If you see bleed in these areas, it's likely pointing towards hypertensive bleed, okay? And then the pathophysiology attributed to this hypertensive bleeds is lipohyalunosis of the small cerebral vessels in the branch arteries. Then later on, when these vessels are weakened, they tend to form aneurysms, and those aneurysms rupture. They are called as the Charcot-Bouchard microaneurysms. Okay. Okay, cerebral amyloidosis, or also known as the cerebral amyloid angiopathy. This one is increased, particularly with increasing age, and there is amyloid protein deposition in the cortical capillaries, arterioles, and small arteries. then expanding into the media and adventitia. This again, the amyloid further replaces the small muscle tissues, and then as a result, microaneurysms are formed, later leading into bleeding. Okay. It's really rare to find amyloidosis, cerebral amyloid angiopathy in the deep structures in the basal ganglia and brainstem. So it's mainly a risk factor for lobar hemorrhage, particularly if you see multiple lobar hemorrhage, then that should tip you towards cerebral amyloidosis in the elderly patients. So the lobar hemorrhage like this. And this one, the most lateral part on the left side is GRE, gradient echo sequence. It's really quite sensitive to detect hemosiderin. So you can see how extensive and multifocal the bleed is in this image. So this should tip you towards cerebral amyloidosis, and you can see that it's quite peripheral, and you don't see much things in the deep structure. So that's called as cerebral amyloidosis. Okay. Coming to the treatment of hemorrhagic stroke, so we are aggressive in controlling blood pressure for hemorrhagic stroke as opposed to ischemic stroke, because if we don't really control the blood pressure, then rise of ICP and then later on hemorrhagic expansions and then herniation is quite high. We don't want to lower it too much as well, but in general, our systolic blood pressure target is less than 160. And if there are any reversible hypercoagulopathies, for example, if patient's INR is high and so on, we should reverse it. We should reverse it by different mechanisms, giving like vitamin K and cryoprecipitates and PCCs and so on. And then basically the other parts of the management are more or less the same. You need to elevate the head of the bed to 30 degrees. You should do swallow evaluations to prevent aspiration and consider NG tube in the appropriate patients, DVT prophylaxis, maintaining euthermia, glycemia, having adequate hydration, nutrition, and early mobilization is important also in this group of patients. Complications from hemorrhagic stroke are really obstructive hydrocephalus from blood extending into the ventricles, or huge bleed compressing the ventricles from outside. So resulting in obstructive hydrocephalus and mass effect from the hemorrhage, and then perihemorrhage edema that really peaks within the first 72 hours. Lasting for up to 5 days is another important risk factor. So it can go up to 5 days, but usually ICH expansion occurs in the first 6 hours. Okay. In secondary prevention, again, also hemorrhagic stroke can happen the second time, the third time, if you don't have proper measurements in place. So in hypertensive ICH, you should really optimize your blood pressure. And in cerebral amyloidosis, you should definitely avoid aspirin and anticoagulation. Okay. Coming to stroke in Zambia. Okay. There were a colleague of ours that did a survey among 250 stroke patients, 162, that is around 65% of them were having ischemic stroke, and that of the remaining patients had ICH. And hypertension among these 250 patients, stroke patients, 71% had hypertension. Imagine how significant of a stroke, how significant of a risk factor hypertension is for stroke patients. And then 23.6% of patients had a recurrent stroke. So this shows that there is a lot of job that needs to be done to prevent and maximize our secondary stroke preventions, because the second time a stroke is happening, it's going to be more severe, right? More fatal, and patients are going to have increased disabilities, okay? So the recurrent strokes are very bad. So we should really work on our secondary preventions. And alcohol was a significant risk factor. And then 25.4% of this cohort of 250 patients had HIV infection. As you know, HIV increases your risk of stroke compared to the general population because of that risk of chronic inflammation. And then, of course, it also predisposes you to different OIs, different viral infections like varicella zoster, syphilis, and so on, that really increase your chance of having stroke. And co-infection with hepatitis B and C is also another factor that will increase your stroke. So the virus itself can also result in stroke. So HIV is really an important factor for stroke. Okay. And then, so there was also, in some patients, there was a risk for smoking, diabetes, AFib, and dilated cardiomyopathy. These were in terms of identifying the risk factors. As you can see, significantly, we had a patient that had HIV, AFib, and hypertension, okay? In terms of severity and outcomes, so it was our patients had a significant correlation in terms of the higher NIH stroke scale you had, the higher likelihood of severe neurologic impairment, also a higher modified Rankin score, as well as having a higher modified Rankin score will give a bad outcome. Okay. And then factors that were significantly associated with stroke mortality were having a female. So as you know, if you have a p-value of less than 0.05, it is said to be significantly associated. So your p-value can vary based on the agreements you have when you start your research. So for this population, their cutoff value was p-value less than 0.05. So all of these things listed here had a significance. So presence of pneumonia, could be aspiration pneumonia or hospital-acquired pneumonia. Likely this is probably an aspiration pneumonia. So your chance of mortality are increased by having this one. So aspiration pneumonia is very important in screening and preventing it. Okay, having a GCS of less than 8 was also associated with mortality, and having an NIH stroke scale impairment of point of greater than or equal to 14 was also associated with significance. And then those that had hemorrhagic stroke had also a higher chance of mortality. Okay. Having said all of this about the crisis we are in terms of stroke in Africa, particularly the sub-Saharan Africa, we are also really hopeful in improving stroke care for our patients. So I'm really happy and excited to share with you that Zambia launched its first stroke unit on October 7, 2023. In UTH, and it's currently fully functional. We have 12 beds, 6 for females and 6 beds for males in the EO1 and EO2 acute, in the EO1 and EO2. So yeah, we will continue together to prevent and decrease and treat patients with stroke better. So thank you so much. I end my presentation here. Thank you.